Okay, my name is Taylor, and we're going to be talking about acid-base regulation today and how the body maintains it. So it's really important to maintain a balance in your pH. pH is determined by hydrogen ions. Normal pH is going to be between 7.35 and 7.45. And it's important to maintain this balance because your body is constantly producing acid from different reactions going on. You've got lactic acid from anaerobic fermentation, phosphoric acids coming from nucleic acid catabolism. If you are catabolizing fat, you've got fatty acids and ketones as a result of that. Or you've also got carbonic acids coming from carbon dioxide. So you have to have a way to manage those extra acids and keep yourself in that range. The body does this with three different systems. There's the buffer system, which includes bicarb, phosphate, and protein systems, and we'll go into details about each of those. Respiratory control and urinary or renal control. So like I said, we'll go into more detail about each of those as we go through the slides. The buffer system is going to basically take care of that hydrogen ion. If a hydrogen ion concentration is rising, it's going to remove it, or if it's falling, it's going to release it. So bicarbonate is one way that we do that. We've got that equation that you see there. It can go to the right, it can shift to the left depending on what the body needs. So you've got a carbon dioxide plus water. It can form, join together and become H2CO3, and then that can dissociate to form a bicarb and a hydrogen ion. And the optimal pH for this one is 7.4. And it works because the lungs and the kidneys are constantly removing CO2, and so it prevents an equilibrium from being reached. So the equation is constantly moving to the left with more H plus being neutralized. You've also got the phosphate buffer system. So you've got a dihydrogen phosphate ion that can release one of its H pluses as needed. The optimal pH for this one is 6.8, so it's going to be important in the renal tubules and the intercellular fluid where phosphates are common and where pH values are lower. And finally, you've got the protein buffer system, and these are just going to have side groups that can either release an H plus or join together with an H plus. So you've got a carboxyl side group that can release an H plus, or you've got that amino side group that can grab hold of an H plus and take it away. And this is actually going to do 75% of the chemical buffering system. Respiratory control is going to work the fastest, takes seconds to minutes, but it's going to be less effective and less permanent than renal control. The body is constantly blowing off CO2. CO2 raises the H plus concentration and therefore lowers pH and makes you more acidic. So the more you blow it off, the more alkalotic you can become. CO2 is constantly produced by aerobic metabolism, and so it's going to need to be eliminated by the lungs at an equivalent rate. And the lungs know to do this because if you have a falling pH and you're becoming more acidotic, it will stimulate peripheral and central chemoreceptors, which will increase your ventilation, and that's going to increase your expelled CO2 and reduce the hydrogen ions. You also have renal control, and like I said before when I compared it to the respiratory system, this is the most effective system. It is actually getting rid of hydrogen ions, which makes it unique. But it's also the slowest. It takes days for this to be able to work. And it does this by secreting hydrogen into the tubular fluid via a sodium-hydrogen ion exchange, and then that in turn goes into the urine to be excreted. And it can also increase the HCO3 in the blood as well. The limiting pH here is 4.5, so as soon as you get below 4.5, the kidneys aren't able to function well anymore, and it won't be able to work. So you can have disruption in the balance, and this is why it's important that we have mechanisms to compensate or try to get back to that original balance. So if our pH goes below 7.35, we're going to be acidotic. And obviously if it goes above 7.45, we'll be alkalotic. So if you are in acidosis, you have an H plus extracellular concentration that's high, and so it's going to diffuse down the concentration gradient into the cells. to maintain that electrical balance that we need, a potassium is going to leave, and this is going to make that resting membrane potential more negative, and it'll put the cells into a hyperpolarized state, and this is going to make it more difficult to stimulate nerve and muscle cells. So it can lead to things like CNS depression, confusion, coma, etc. And you can also have alkalosis, of course. So the exact opposite is going to happen here. You're going to have a low concentration of hydrogen ions, and so they're going to diffuse out of the cell. Potassium, to compensate, is going to move back in, and your cell membrane potential is going to become more positive, and that's going to make your cells closer to that action potential that they need, and it's going to make them more excitable. So as a result, you'll get spasms, tetany, convulsions, and things like that. So acidosis and alkalosis states can be caused by either respiratory or metabolic failure or trouble. So if you're in respiratory acidosis, it can be because of something like hypoventilation. So your breathing rate is slower, you're not getting rid of as much CO2 as you usually are, and so you're going to become acidotic. This is going to happen when the rate of the alveolar ventilation is slower than the body's production of CO2. So that CO2 will increase and you will become acidotic. One example among many is a patient with emphysema because they've lost their alveoli and they can't keep up with the rate of CO2 production. You can also have respiratory alkalosis. So this would be due to something like hyperventilation, where you're going to be blowing off too much of that CO2 and become alkalotic. An example of that might be something like a panic attack. And you can also go into different states because of metabolic problems. So you can be metabolically acidotic. And this is going to be due to many different things. It could be increased production of acids, ingestion of acidic drugs, or it could be like something like a loss of base. So, for example, if you are a diabetic that's uncontrolled and you're trying to derive energy in ways without using glucose, you'll be producing ketones, and this will make you more acidic. So this would be an example of metabolic acidosis. Metabolic alkalosis is rare, but it is possible, and this is obviously going to be just because you've decreased the acid in your body, and this could be from something like chronic vomiting. So obviously the contents in your stomach are acidotic, so if you vomit them and expel them from your body, you will become alkalotic. So when your body goes into one of these states, there is compensation that should hopefully be happening. So if you go into metabolic acidosis or alkalosis, it's going to be compensated for by the respiratory system. And the respiratory system will either hyperventilate or hypoventilate depending on what it needs to do. So this is really affecting at correcting a pH imbalance due to abnormal pressures of carbon dioxide, and less so when it's a metabolic problem like increased ketones in the blood. And obviously you're going to be able to do respiratory acidosis and alkalosis compensation by the renal system, and it will just change the rate of hydrogen ion and bicarb excretion. And like I've said before, this is slow, so it's not good for the short term, but it's the most effective. So ABGs are a common lab that you might order to check your patient's acid-base balance. It can show you which system is failing, which might clue you in to what is actually going on in their body, and it can show you if the other system has compensated or not, which might tell you if this problem has been going on long term, it's more likely to be compensated than if it's just short term. Those are our normal values for everything. Those are also what you'd be getting from an ABG. So you get a pH, pressure of carbon dioxide, which should be between 35 and 45 millimeters of mercury, and a bicarb between 24 and 28. So let's do a couple practice problems and see what we've learned. So patient A presents with the following ABGs, and just to remember, those are the normal ones. So let's first figure out if they are acidotic or alkalotic. Well, their pH is 7.31, and this is lower than normal limits, so I think they are acidotic. And which system is failing? Let's look at pressure of CO2 first, which would represent our respiratory system. It's at 55. Normal should be lower than 45, so that means it's high. So would you expect a patient to be acidotic if their carbon dioxide pressure is 55? I think you would. So I think this person is in respiratory acidosis. Let's look and see if they're compensating or not. Let's look at the bicarb, which would be metabolic representation. So it's at 28. And within normal limits, it is within normal limits. And this means that the body isn't compensating. It's not increased that base to compensate for that increased acid. So this patient is in respiratory acidosis with no compensation. Let's do another one. Patient B presents with the following ABGs. There's normal for you. So are they acidotic or alkalotic? Well, it looks like their pH is above normal limits. That means they're alkalotic. Which system is failing? Let's see whose fault it is. So carbon dioxide's at 55. This is higher than normal. Would you expect a patient to be alkalotic if their CO2 was high? You wouldn't. So let's look at bicarb next. Their bicarb is 32, which is higher than normal limits. So would you expect that patient who has a high bicarb to be alkalotic? I think you would. So their metabolic alkalosis is their compensation. Well, that PCO2 is high, so it's trying to increase the acid to make up for that increased base. So yes, it is compensated. So this patient is in metabolic alkalosis with partial compensation. So last question, you got another patient A, who is 67 years old. He's a male, smoked 2 packs per day for the past 49 years. He appears thin, is bracing himself to breathe, and is using accessory muscles. So which of the following ABGs is most likely his? So we've got 3 to choose from, and there's normal. So to me, it looks like this patient has emphysema based on his history and the picture provided. So a patient who has emphysema is going to not be able to keep up with the rate that the body is producing CO2 because, like we talked about before, they've lost alveoli. So I think they're going to have an increased CO2 due to his respiration. So I would expect this patient to be in respiratory acidosis. So let's look through our options to see which one is that. So option A, the pH is 7.5. Well, that's too high. That's alkalosis, so I think option A is out. Option B and C are both acidotic, so I think it could be B or C. So we need to find the one that indicates that it's respiratory acidosis. So let's look at option B. His PCO2 is 49. This is higher than normal, and would you expect a patient with a high PCO2 to be acidotic? You would. So I think option B is a good option. He is definitely respiratory acidosis, and if we look at his bicarb, he is partially compensated, which makes sense because emphysema is a long-term chronic problem. Let's just be sure to look at option C. He's acidotic. His PCO2 is 33, which is lower than normal, and we wouldn't expect someone with a low PCO2 to be acidotic. So let's look at bicarb. That's low, and that makes more sense that this would be metabolic acidosis. So I think the answer is B. You would expect an emphysemic patient to be in respiratory acidosis that is partially compensated. And that concludes my presentation, and there are some references for the pictures that I used. Thank you very much.